I request all the presenters to keep your presentations time-bound and crisp. And instead of reading the lines, it would be great that if you can explain the slide in a gist and move on to the next slide. And wish you all the best for this session. It's a very friendly session, and let us have an academically rich session. So over to the first presenter.
Dr. Parth.
अच्छा पार्थ प्रजापति।
Topic for Dr. Parth is Dr. Parth.
हाँ, peripapillary artery thickness comparison between normal population and type 2 diabetes। ये मोटे में लिखा है।
Good afternoon everyone. Myself Dr. Parth. I am presenting the study about peripapillary RNFL thickness comparison between the normal population and type 2 diabetic patient. As we all know, diabetic retinopathy is one of the leading cause of blindness in working adults. There are 190 million people with diabetic retinopathy worldwide. There is a rapid increase in cases of diabetic, and there is an estimation of 191 million people will be suffering from this disorder by the 2030. In India, there is a prevalence of 10.3%, and in Gujarat it is a 10.6%. Microvascular disease and neurological complications are the known serious complications associated with the diabetic retinopathy. Diabetic neuropathy is supposed to affect neurons, and thus measurement of the RNFL thickness in this diabetic patient can helpful to diagnose the development of diabetic neuropathy. In such cases, a spectral domain OCT has ability to show a thinning of retinal nerve layers in the absence of visible diabetic retinopathy changes. The main objective of study is to compare the RNFL thickness in normal population and type 2 diabetic patient without retinopathy changes using the spectral domain OCT. It is a cross-sectional study, and total number of patients are 300, and age group there is a 150 patients, and consecutive sampling was done in the OPD. The patient are those who had diabetes and fundus, so no any changes of retinopathy. This study not involves the patient who had a glaucoma or retinopathy changes, myopia, optic neuropathy, ocular trauma, hypermetropia, any laser procedure. Here there is a study shows there is a one total population 300, out of which 91 is the male in group A, 87 is group B, 59 females in group A, and 63 in group B. And there is a non-normal population. The SB1C is around 6.2, in diabetic patients 7.3, and FBS is 121 normal population and 135 in group B diabetic patients. Here we can see that there is a age and gender match control, and there is a high HbA1c level in diabetic patient as well as high FBS level comparative to normal population. Here it shows there is a RNFL measurement are taken by the SDOCT. It in all quadrant average RNFL thickness and quadrant wise RNFL thickness has been taken. Here we can see that in normal population the superior 121 comparative to group B diabetic patient, it has been lowered to 94. In inferior, in normal population it is a 134, in diabetic 90, in nasal quadrant it is a 91, in normal population 67 in diabetic, as well as in 67 in temporal area in normal, and 57 in diabetic patient. So here we can see that there is a comparative RNFL thinning is seen in diabetic patient compared to normal individual. And there is a significant thinning in the inferior quadrant and the superior quadrant of the RNFL region. So my conclusion of study is that neurodegeneration serves as a early indicator of diabetic retinopathy. So early regular monitoring and measurement of RNFL can be helpful to avoid the retinopathy changes and further complication associated with diabetes. Thank you.
Can you show your conclusion again?
Ma'am, it shows there is a neurodegeneration preceded before the retinopathy changes in patient. So we can monitor the patient for regular diabetic management and the regular follow-up for the avoiding the retinopathy changes.
Did you get any value? How much degenerative changes? How will be the progression of these? P-value was significant in both the groups, as
Yes.
you showed.
Yes.
So was there any value calculated that how much degeneration occurs in what time?
No, ma'am.
It was a cross-sectional study. okay.
cross-sectional study. Only comparative analysis. has been done.
Comparative analysis. Okay.
Dr. Path, which machine have you used for this?
Ma'am, sir, tractor SDOCT in our OPD SDOCT is available.
Did you analyze how is the GCL while you analyze the RNFL? The GCL analysis at the macula itself?
No, sir.
Because the RNFL is just a continuation which is going from the GCL itself. So a better analysis would be first to see how the GCL are doing, or at least it should have been a comparative that the GCL are affected along with it.
Okay.
So and the last thing I want to know is that how did you differentiate it that it's not a glaucoma which is affecting the RNFL?
Actually, sir, I have done the before the screening of the patient, the NCT and the fundus examination has been done. The patient tension is around the normal and the fundus examination, so there is no glucometers changes in the patient. There is no other family history or any topical AGM uses in the patient.
All right.
So duration of diabetes is a very important factor.
Yes,
So
sir.
it is very difficult to ascertain in type 2 diabetes how long the diabetes is. This is a rough estimation you have taken. So how much is the duration of diabetes in your patients?
Sir, actually, they are the recent diagnosed patient, recently diagnosed
Recently,
patient.
fresh cases of
Freshly,
diabetic retinopathy. Okay,
Okay, thank you.
thank you.
Next.
So next, I call upon Dr. Sai Harshita Pothimarthi. Her talk is on utility of PVEP detecting early neurodegenerative changes
Is
in
she
diabetic
present?
patients.
Dr. Sai is not present at the moment. I think
Okay.
the next speaker would be Dr. Priyadarshini Singh.
Priya Darshini Singh is present. So come.
Please. Dr. Priyadarshini Singh will be presenting on early detection of retinal microvascular alterations in type 2 diabetes using OCTA biomarkers.
Good morning, respected chairperson, faculties and my dear colleagues. I am Dr. Priyadarshini Singh and I am honored to present our cross-sectional study titled as Early Detection of Retinal Microvascular Density Alteration in Type 2 Diabetes with and without retinopathy using optical coherence tomography angiography. Diabetes mellitus is a leading cause of microvascular complication, and diabetic retinopathy remains one of the foremost causes of preventable blindness worldwide. Scientific evidence suggests neural and vascular retinal modification can occur before clinical visible signs of diabetic retinopathy. This raises an important question that can we detect these silent changes before retinopathy becomes clinically evident? This is where OCTA comes in. Unlike fluorescent angiography, OCTA is a non-invasive dye-free imaging modality that uses low coherence interferometry to capture high-resolution 3D images of the retinal and choroidal microvasculature. It allows to detect early microvascular changes, including remodeling and enlargement of the foveal avascular zone, suboptimal vascular density, capillary non-perfusion, venous bleeding, increased vascular toxicity. Our aim of the study was to analyze retinal microvascular density alteration in type 2 diabetes with and without retinopathy using OCTA. Primary objective were to compare the retinal microvascular density in the patient with type 2 diabetes mellitus. Secondary objectives were to evaluate the potential of OCTA as a diagnostic tool and to correlate retinal microvascular alteration with the severity of diabetic retinopathy. This hospital-based cross-sectional study was conducted over 12 months with 63 patients, 32 patients with diabetic retinopathy and 31 without. The inclusion criteria were confirmed diagnosis of type 2 diabetes mellitus for at least 5 years, adult aged 18 years and older, the ability to undergo OCTA and informed consent. Exclusion criteria were other retinal diseases, ocular surgery or trauma, systemic condition that might independently affect retinal vasculature, poor OCTA image quality, use of medications known to affect the retinal vascular independently of diabetes, and the compliance of the participants. All participants underwent OCTA imaging, using a commercially available device, image acquired for both the superficial and capillary plexus. Automated software were used to quantify retinal vessel density, foveal avascular zone. Manual verification were also performed to ensure accuracy. Among the participants, 59% were male, 41% were female, mostly aged between 50 to 69 years. The mean duration of diabetes was 10 years and the average HbA1c value was 8.2%. In diabetic retinopathy group, the most patient had mild to moderate NPDR. Now coming on to the results. In superficial capillary plexus, the vessel density was significantly reduced in the diabetic retinopathy group. Foveal vessel density dropped from 16.2% in non-diabetic retinopathy eyes to 13.8% in diabetic retinopathy eyes. Similarly, parafoveal vessel density decreased from 48.7% to 44.2%, and the whole image density reduced from 47.9% to 42.6%. Changes were even more striking in deep capillary plexus. The foveal density fell from 18.9% in non-diabetic retinopathy eyes to 15.7%. The parafoveal density declined from 52.4% to 47.6%, and the whole image density from 51.1 to 45.9%. These findings highlight that microvascular compromise is more pronounced in the deep capillary plexus. We also observed significant enlargement of foveal avascular zone. In superficial capillary plexus, the mean FAZ area was 0.29 millimeter square in the non-diabetic retinopathy group, whereas it increased to 0.38 in diabetic retinopathy group. These findings indicate that FAZ enlargement was strongly associated with the presence of retinopathy, reflecting progressive microvascular dropout in both superficial and deep retinal layer. These are the graphs showing, the first one shows the OCTA vessel density versus the diabetic retinopathy severity, and the second one shows the increased FAZ area by increasing the diabetic retinopathy severity. In conclusion, this cross-sectional study demonstrated that retinal microvasculature density was significantly reduced in patients with type 2 diabetes mellitus. The decline in vessel density was evident in both superficial and deep capillary plexus. In addition, the patient with retinopathy exhibited larger foveal avascular zone which reflected advanced microvascular compromise. These findings highlight that OCTA is not merely a research tool. It can detect early microvascular changes before clinical retinopathy occurs. Early detection could enable early intervention and better outcomes for diabetic patients. Thank you.
Thank you, Dr. Priyadarshini. I think you should have taken care of the time. However, we have less speakers but then the time is allotted and everybody has to finish within that time. My question is, have you taken into consideration the vision and these findings, or the functionality of that area by means of ERG, multifocal ERG.
Sir, I can't follow your question.
You see, you said about the thickness. What I'm saying is, did you correlate it with the visual acuity of the patient?
Yes, sir. Yes, sir. When the vision was correlated with the severity of the disease. Mild NPDR and moderate NPDR did not show reduction in visual acuity as such in earlier cases. But the severe NPDR and PDR cases had low visual acuity.
Do you have ERG with you? ERG? Okay.
No, sir.
Sir.
There's one question, Dr. Priyadarshini. How did you quantify this vascular density? The superficial and deep capillary plexus you have used. So what is the value you were using, or was it a photographic comparison which you have done to quantify the images?
Sir, it was through automated software in the OCTA and manual verification.
Can you elaborate about the software?
No, sir, it was
Which machine have you used for this?
sir, spectral OCTA.
Yeah, but I don't know of any software which per se calculates vascular density, or you have to do it manually, but there's no machine. Anyways, just look into it, because we cannot compare the vascular density without a proper cube or formation, and then we know that superficial this much density it is there and in deep it is there. So you need to go back to your raw data and see what values have you put and how you have put it.
Yes. Thank you, sir.
Did you exclude the cases of diabetic macular edema in this?
Yes, ma'am. Yes, ma'am. In the exclusion criteria, I have written that other retinopathy, other changes that can affect the retina were excluded.
And what about taking the clear images? Was there any exclusion criteria
Yes,
for
ma'am.
that?
Poor OCTA images were excluded in the study.
Can you explain poor? What do you mean by that?
In the software, there is a more than 50% of the right percentage it is there. So above 50%, I have used that images only.
Okay. Okay, all right.
So thank you.
Thank you, sir.
Next.
Sure.
Next comment.
Dr. Debarnab Deb. Dr. Sai, are you here? Dr. Sai, Dr. Rita Palli, Dr. Romadas. Okay, please go ahead.
Can we have the slides, please?
Is Debarnab Deb.
Good afternoon, respected chairperson, respected judges, and everyone present here. Myself, Dr. Debarnab, a postgraduate trainee from Silchar Medical College and Hospital, and topic of my presentation is retinal arteriovenous ratio, a window to cardiovascular risk prediction. We as ophthalmologists have long cherished the art of restoring vision. However, through ocular screening, we hold the power to detect systemic diseases early, extending our impact from saving lives to saving vision. The retinal vasculature offers us a unique, non-invasive window into systemic microcirculation. By studying the arteriovenous ratio, we are in fact assessing the vascular health of the entire body. Alterations in this ratio are not merely ocular findings, but they detect a systemic alteration as well. Reduced arteriovenous ratio predicts future cardiovascular events independent of risk factor, and this measurement will allow us for reliable risk stratification. The primary objective of this study was to assess the relationship between the retinal arteriovenous ratio and cardiovascular risk using Framingham risk score, with a secondary objective to evaluate the association of arteriovenous ratio with hypertension and diabetes mellitus, as well as to assess the retinal imaging as a non-invasive cardiovascular risk prediction tool. So our study was designed as a 12-month cross-sectional observational study, under which we enrolled 90 adults through consecutive sampling based on inclusion and exclusion criteria. Data collection involved retinal imaging along with clinical data, which included age, gender, blood pressure, diabetes status, lipid profile, as well as smoking status. Retinal vessel analysis was done using an image software, and the vessel diameter was calculated using the Knudsen-Hubbard formula. Risk assessment of the patient was done using the Framingham risk score, and finally the statistical analysis was performed. So coming to the inclusion and exclusion criteria, we included participants aged 45 to 70 years of age with or without established cardiovascular risk factor, and who had the ability to undergo retinal OCT imaging and had the variables which are required to compute the Framingham risk score. The exclusion criteria included dense media opacities, retinal vascular occlusion diseases, proliferative diabetic and severe diabetic retinopathy, and patients with macular edema. Patients who had laser treatment in the retina or intraocular surgery within the last 3 months were also excluded. The patients with high myopia with more than 6 diopter or significant optic disc anomalies and recent cardiovascular event and pregnant patients were also excluded from the study. So this slide showcases the code of our work, the Retivis software, which was indigenously developed with the help of students from National Institute of Technology, Silchar. The process is simple. We first upload the fundus image, which you can see here, and following which the optic disc is marked, and the venules are tagged in blue in color, and the arterioles as red. And following which the software will automatically measure the diameter of the vessels, and the arteriovenous ratio will be calculated using the Knudsen-Hubbard formula, as we can see here. So all the authenticity of the software was measured using 40 fundus images, which are already measured in the EVAN software, and we got significant authenticity of the app. So coming to the resultant analysis, the mean age of the participant was about 52 years with a fairly balanced gender distribution, and there were notably 44% of hypertensive patient and 31% of diabetic patient, as you can see here. The graph on the left shows negative correlation between arteriovenous ratio and Framingham risk score with a correlation coefficient of -0.47, and graph in the right shows we have distributed the patients based on the risk factor on Framingham risk score, and the mean AV ratio declined as the risk increases. Again in the left we can see that the hypertensive and diabetic patients had significant lower AV ratio as compared to the normotensive and non-diabetic patients, and the graph in the right shows an area under curve of 0.81, which confirms the predictive ability of arteriovenous ratio in identifying the high cardiovascular risk. Thus, to summarize the findings of the study, we found a significant negative correlation between the arteriovenous ratio and Framingham risk score, which directly corroborates the work of Hubbard and Ikram, and therefore you can say retinal arteriovenous ratio shows promise as a non-invasive cardiovascular risk marker, especially in resource-limited setting. To conclude, we have confirmed that the retinal arteriovenous ratio is a robust, independent, and non-invasive predictor of cardiovascular risk. Going further, large multicenter longitudinal studies along with its use as a potential for screening in primary care setting is required. These are the references that I have used. Thank you.
Thank you, Dabandev.
I request all to adhere to the timeline. Out of 3, I think 2 have exceeded that. So please finish within the timeline. And can you elaborate your results?
So ma'am, actually we have calculated the arteriovenous ratio of 90 patients. So out of which, ma'am, we have seen that, and also we have stratified the patients according to the Framingham risk score, which have divided the patients into low, medium, and high risk group of patients. So as we have seen that as the risk of the patient increases according to Framingham risk score, the arteriovenous ratio decreases accordingly and significantly. So this shows that with increasing risk of cardiovascular risk, the arteriovenous ratio decreases, and which can be used as a screening tool for detecting cardiovascular risk early.
Dr. Dev, is this an indigenous software which you have made?
Yes, sir. Yes, sir. We have actually took the help of students of NIT Silchar who made us the software.
And does it show the flow cytography also?
No, sir.
Not yet.
Actually, it's a prototype. We are detecting the vessels manually as of now. The only thing is that they measure the diameters on their own, but the vessel selection is done manually.
So what are these sort of fundus photograph of? which camera, slit lamp in 90D or Optos?
No, we use the photographs of fundus photo and that I took from spectral domain OCT machine.
No, this is a true color images you have taken. This is not a spectral domain OCT fundus photograph. These are true color images which you have taken, and then you have collaborated it with the machine. Thank you.
Thank you. So Dr. Bhavna Chawla, I cannot see her. Dr. Gaurav Mahajan, yeah, you can come.
Come.
Dr. Gaurav Mahajan will be speaking on a study of dynamic pupillometry in patients with type 2 diabetes mellitus and non-diabetic controls.
Good afternoon. I'll be speaking on a comparative study of dynamic pupillometry in patients with type 2 diabetes mellitus and non-diabetic patients. So, a normal pupil reaction is a balance between the sympathetic and parasympathetic nervous systems. The inner circular muscles are supplied by the oculomotor nerve. External muscles are supplied by the sympathetic fibers from the cervical ganglion. Pupil evaluation forms a critical component of neuropsychological and ophthalmological evaluation. Aims and objectives are to determine and compare the dynamic pupillometry parameters in patients with type 2 diabetes mellitus and healthy participants, and to determine the relationship of these parameters with age, gender, duration of diabetes and HbA1c levels. It was a cross-sectional study. We took 1600 eyes of 800 patients, age ranging from 20 to 80 years, divided into two groups, group 1 with diabetes, group 2 controls. After fundus examination based upon the ETDRS criteria, we divided into three subgroups. Group A, no retinopathy, Group B, NPDR, and Group C is a PDR. Inclusion criteria is the patients with diabetes mellitus for at least 5 years with HbA1c of greater than 6.5%. Exclusion criteria rest everything, even type 1 diabetes mellitus patients as well as the patients who have undergone PRP laser, focal laser or intravitreal injection at any point of time were also excluded. This is the device that we have used. This is the NPI 200 device, which was manufactured by NeuroOptics USA. It's a non-invasive device, uses infrared camera, integrates a calibrated light stimulus of fixed intensity of 1000 lux for the duration of 3.2 seconds. Automatically calibrates, focuses and controls the vertex distance and excludes the outliers. 30 images per second are taken, giving a temporal resolution of 33 milliseconds. Dim light conditions of 64.9 lux are maintained in the room, and dark adaptation time of 2 minutes is considered standard. So these are the few images of the measurement being carried out, and this is how the output looks on the machine. So coming on to results and discussion. So different pupillary parameters that were measured include size, minimum pupil diameter, percentage change in the pupil size, constriction velocity, maximum constriction velocity, dilatation velocity, and most importantly, which we will come to know later, is the latency of constriction, that is the time of onset of constriction following initiation of the light stimulus. Then after all these parameters are combined by the machine and they are converted into a neurological pupil index. What is it? It is automatically assesses a patient's pupillary response on an objective scale by comparing the pupil parameters with a normative model of pupil responsiveness to light using a proprietary algorithm formula. So it is graded from 0 to 5. Greater than 3 is a normal pupil response, less than 3 is an abnormal pupil response, and 0 is a non-reactive pupil. Now, when we correlate these pupillary parameters with age, with patients with diabetes and controls, all the parameters are negatively correlated except the NPI as well as the latency, which are positively correlated, and all the parameters are also statistically significant. Then coming on to the comparison of these parameters between type 1 males and type 2 group 2 control males as well as females, in both of them the values were statistically significant. Then coming on to the correlation of the pupillary parameters with duration of diabetes, in this all the parameters had a negative correlation except latency, which has a positive correlation. In addition, all the parameters were also highly statistically significant. Similarly, with HbA1c, latency follows the same positive role, and the rest all parameters are correlated negatively. Coming on to distribution of participants within the subgroups, we had majority of the participants in the mild NPDR group followed by moderate NPDR will belong to 27%. If we compare these parameters within the subgroups, all the parameters had a statistically significant correlation in all the subgroups. Coming on to discussion, all dynamic pupillary parameters varied highly statistically significantly in group 1 and group 2. Participants with type 2 diabetes mellitus have altered pupillary parameters as a result of autonomic nervous system dysfunction. all the dynamic pupillary parameters were negatively and statistically significantly correlated with age except latency, which was found to be positively and statistically significantly correlated with age. So NPI had a positive correlation with age. This is a scatter plot which shows the positive correlation with age. We speculated as a result of the influence of some of the parameters included in the NPI calculation, which likely showed higher values with increasing age. It is likely that various factors including pupillometry devices, illumination levels used, dark adaptation time, iris color, ethnicity, and neurological status of study participants influenced the variation of parameters. In the current study, other pupillary parameters were found to be negatively correlated with age. This is consistent with the previous studies which concluded that pupillary dynamics slow down with age. Various explanations have been provided for this age-related phenomena, including a comparative atrophy of the dilator muscle relative to sphincter muscle, rigidity of the iris, a decrease in sympathetic tone, a reduction in parasympathetic inhibition, and chronic fatigue. In the current study, all the dynamic parameters were negatively correlated except HbA1c for acceptable latency, which was positively and highly statistically significant correlated. Limitations of the study are the ultrastructural abnormalities in the iris specimens and retinal thickness were not examined in our study, and future research should consider addressing these potential topics to provide a more comprehensive understanding of the subject. Thank you.
What are your exclusion criteria?
Sir, everything other than diabetes was our exclusion criteria. Only the patient that had diabetes greater than 5 years, established case of diabetes, and HbA1c greater than 6.5% at the point of examination.
Dr. Gaurav, very nice innovative study. Was it a machine dependent study?
It was a machine dependent study.
So there is only one single machine which can do all these measurements, right?
Yes, sir. In addition, I would also like to say we have also published another iPhone-based pupillometer device that is also published article. So in that we use the flashlight of the iPhone to calculate the pupillary parameters which have all been mentioned here.
Okay.
They could not be replicated to that level, so this machine remains the gold standard. Actually, this machine we had got from US and this is not available in India. So they use basically this machine at trauma centers to quantify whether the patient is having any subdural hematoma or any other traumatic brain injury. So we have used it in diabetes mellitus patient to check whether we can see the patient is with diabetes can be detected early without the visual changes.
So do you want to say that the diabetes, we all know it's a neurodegenerative neuropathy causing disease. So do you want to say that it affects the pupillary fibers, the nerves to the pupil
exactly.
earlier than the retina nerve fiber?
Because it's a microvascular disease, sir. So since it is a microvascular disease, it ought to affect all the nerves. So in pupillary response is affected the fastest as we see in our study, and rather than the retinal changes that we see.
Just a food for thought, since you said you have a more potential in this, since you have this machine with you, you can compare the diabetic protocol for ERG diabetic protocol versus your pupillary protocol to see which changes are developing first. We all know that diabetes causes neuropathy in our legs, arms, and all those twitching sensation. But is it affecting our pupil first or the retina first? So you can do a comparative analysis, seeing the latency, how it works on.
Definitely.
But anyways, a very good study.
Definitely, sir.
Absolutely, sir. That's a very brilliant idea because that would be very purposeful to explain that.
Yes,
Also, I would like to know what do you mean by NPI, neurological?
It is a neurological pupillary index. It is the value which the machine itself calculates. We have given many emails to the manufacturer of this machine, but they have refused to tell how they calculate NPI. They just said it's just software based which is present in the machine. It will calculate all the values that I have shown and automatically get the NPI value for us to score the patient up till on a score of 5 so that we can evaluate.
Okay.
Thank you.
Thank you.
Anybody else? Or present?
Dr. Zaid. Dr. Zaid Ashraf.
He is there. Which number? कौन सा number है?
Any other speaker present here? What's your name?
Shivani. अच्छा, she is the keynote address, no? Keynote address.
Okay.
We can have
After this.
Good afternoon, everyone. I would be presenting my study on prevalence and risk factors for ARMD in a tertiary care center of Jharkhand by screening individuals above 50 years of age. So to introduce, ARMD is a senile macular degeneration due to pigmentary and atrophic changes in macular region causing impairment of central vision with increasing age. ARMD accounts for around 8.7% of the total blindness globally, which is the third most common cause of visual impairment after cataract and glaucoma. It is the prevalence of ARMD in India ranges from 1.8% to 4.7%. Aims and objectives of my study was to estimate the proportion of age-related macular degeneration patients aged above 50 years attending our IOPD, and to study the associated risk factors in case of ARMD. Materials and methods used were, it was a hospital-based cross-sectional study conducted between January 2023 to December 2024. A study population included patients attending IOPD above 50 years of age. Sample size of 300 was taken. A study site was RIO RIMS Ranchi. Excluded patients were those having corneal, lenticular or vitreous opacities in which fundus examination was not possible, and other associated conditions such as myopic chorioretinal degeneration, angioid streaks, any macular dystrophies were also excluded. Data pertaining to socio-demographic factors were calculated, BMI was calculated, uncorrected, best corrected, and pinhole improvement of the vision was checked. Slit lamp biomicroscopy and fundus examination was conducted. Specific signs of ARMD were looked for, and the patients were graded into following 4 groups: no ARMD, early, intermediate or advanced cases. Patients having changes of ARMD were then examined using Amster's grid chart 1. OCT and FFA was done for the confirmation of clinical findings in every patient. This is the FFA image. A statistical analysis was done. Data management analysis was done using Microsoft Excel and AP Info system software. Frequency distribution graph was prepared. All the tests were considered significant if p-value comes to be less than 0.05. Results: we studied 300 patients attending OPD. Risk factors such as age, sex, residence, etc. was noted. Diagnosis of ARMD was made on dilated fundus examination and was confirmed on FFA and OCT. Out of 300 individuals in our study, we observed 27 had ARMD. And among those 27 ARMD patients, the relation with age was significantly associated between increasing age and ARMD positivity, with p-value being less than 0.05. The statistically significant association was also noted between female sex and ARMD positivity, with p-value being less than 0.001. But no statistically significant association was found in our data with BMI and ARMD, p-value being more than 0.05. And no statistically significant association was found between smoking and ARMD in our study, with p-value being more than 0.05. There was a statistically significant association between family history and ARMD, with p-value being less than 0.001. These are some fundus pictures showing ARMD changes in our patients. To discuss, in this study, out of 27 ARMD patients, 81% were females and 18% were found to be males. And ARMD was significantly associated with old age, which is supported by Framingham and Weaver Dam study. Smoking was not found to be a significant risk factor in our study. A study done by Zhang et al. In China showed a linear correlation between BMI and risk factor of developing ARMD. But in our study, we found no significant association BMI and ARMD. Family history was significant risk factors. There are various genes implicated in pathogenesis of ARMD, such as complement factor H and C3, LOX 3877, HTRA1, etc. So to conclude, the prevalence of ARMD in our study was 9%, with age group being most commonly affected being 71 to 80 years. Females were found to have higher prevalence of ARMD. Smoking and obesity, cataract surgery, sunlight exposures were not found to have significant association. Family history of ARMD was a significant risk factor found in our study. These are my references. Thank you.
Thank you, Zach, for finishing your paper on time. Sir.
A very good study you have done at that India. I think earlier study has been done, but you require more number of patients to actually predict anything?
Yeah. Thank you, sir. Thank you so much.
So, Dr. Shivani, please come.
Dr. Shivani Chaturvedi has to give keynote address. Spot urine albumin protein is a biomarker for severity of diabetic retinopathy. I think she must have got the best paper award. Am I right? She must have got the best paper award. So now I request Shivani to go.
Before she starts, any other speaker present in this hall for this session?
She is from KGMC, and I think under Dr. Sandeep Saxena, she must have worked. Now she is a senior resident as PGI Lucknow, PGI Lucknow. Okay, thank you.
Good afternoon, everyone. Today I'll be presenting my study, Spot urine albumin is a biomarker for proliferative diabetic retinopathy. So raised spot urine albumin levels are an indicator of potential kidney damage in diabetic retinopathy. And spot urine test is a simple, physician-friendly, easily available and reliable test. Spectral domain optical coherence tomography is an accurate diagnostic instrument for defining the in vivo histology of retina. It's like doing a biopsy of retina. Optical coherence tomography, angiography, is an extension of OCT which offers imaging of the retinal vasculature. The aim of our study was to evaluate serum spot urine albumin levels as a biomarker for proliferative diabetic retinopathy and to correlate the stages of diabetic retinopathy with various OCT parameters depicting the neurovascular urine. It was a tertiary care center based cross-sectional study. A total sample size was calculated, that is 104, and it was divided into 4 groups: controls, no diabetic retinopathy, non-proliferative diabetic retinopathy, and proliferative diabetic retinopathy. Spot urine albumin protein was done using a urine test kit, and SDOCT parameters like foveal vascular zone, superficial vessel density, deep vessel density, OCT RNFL, retinal nerve fiber layer, and OCT ganglion cell analysis were done. And we can see in this box and whiskers plot the association between spot urine albumin and stages of diabetic retinopathy. That is, when the spot urine albumin levels increases, the disease worsens. Here we can see that as the disease worsens, the foveal vascular zone is increasing, whereas the vessel density is decreasing. As the disease progresses, OCT RNFL and ganglion cell layer also is damaged. Based on the ROC curve analysis, the spot urine albumin levels emerged as a highly sensitive and outstanding biomarker, and area under curve of 1 for PDR, and the cutoff values for conversion from NPDR to PDR came out to be 189.5 milligrams per day. So to conclude, we can say that spot urine albumin is a noble biomarker for proliferative diabetic retinopathy, and it predicts the progression from NPDR to PDR, and it correlates significantly the OCT-A parameters like vessel density and foveal vascular zone, and also the RNFL layer and ganglion cell layer on the OCT. Thank you.
Thank you so much. Excellent study, and rightfully deserved the prize.
For questions?
Any questions from audience?
So basically, prevention of diabetes is one of the important factors, as Dr. Shivani has said, and we have also done the urine albumin 10 years back. So albumin is one of the criteria which should be taken as thing. So just for the Shivani, what is basic research to guide them? You know, this is not a simple but basic research, but had predicted something. So everybody, young generation, must do some research. And research is very important part of the thing. People are going into practice, but research is very important because it stimulates your brain. And the people who are doing research, their circuit is all right. Alzheimer's, dementia is less. Sir, anything?
No, sir, you're going to go fantastic. Very nice.
And Dr. Sandeep Saxena is always doing some research for the last many years. So thank you for presenting. Go on. Thank you.
Any other presenter who's present? Okay, so with
टाइम
that,
है अभी, टाइम है अभी कुछ बता.
sit. Time is,
Time
we
हो
have
गया.
half an hour more. So should I conclude?
हाँ, conclude.
So with this, we would like to conclude the session. It was very nice presentations by all, and may the best one win. But even if you have not won, doesn't mean that you stop here. You should go on with your work and present it or continue it on the further platforms. So all the best to all of you. Thank you.
Thank you.
So, with the consensus before the time, can we leave? Because if somebody
Anybody would like to take guidance from him, from me, I am head of Retina, she is the faculty member. Any would like to talk about any research, any topic, anything you would like to ask? हाँ बताइए, आ जाओ. Mike.
So we did one research where we were correlating the glycated hemoglobin levels with the OCTA parameters. So basically that study has been done, but we were searching for the microvascular changes that cannot be discerned clinically.
Yes.
We can see them in the OCTA reports. So what else can we do to make this research better? Because most of the work has been done on glycated hemoglobin, but how to correlate it with the OCTA levels to make it better?
हाँ बताइए.
So to my mind, if you can correlate all these, the functionality of that area, that is fovea and macular area, by a multifocal ERG, that is going to help you out. And sometimes, many a times, the vision is not going good and there is some confusion. Again, the ERG is going to help you, that is the pattern ERG. So the ERG is going to come up in a very big way. They'll correlate a lot of things.
We have done multifocal ERG 15 years back, and you correlated the functional status. Severity is more severe is the thing, the multifocal ERG's findings were there. So basically for younger generation, don't go, there is a external research. You know, lot of machine, next 10 years, lot of changes will come. There is the internal research, whether they call time track method. So anybody interested to know time track method, in which you will know what machine will come after 50 years. You know, that is the beauty of this thing, because lot of changes are going to, OCT will change, everything will change. We are going more and more in depth. And also,
That is what newer machines like adaptive optics and all, multifocal ERG, you can do studies on them, that can, and we can discuss it also later, that what exactly you want, because it is a very wide topic. So how we can study one parameters or compare few parameters which can give us some meaningful results, that can be.
chaliye, thank you.
Okay, thank you. Let's come forward for the photograph.
Yes.
मैडम आपका वो शीट दे दीजिए. शीट, या. Have you signed?
आ जाइए प्रेजेंट आ जाओ शिवानी. इधर से ही आ. अच्छा आगे आ गया. आप वो